want to move on to the next portion of our meeting. And again, thank Dr. Evans and Dr. Willard and Dr. Burkle, who are really provided an important base in terms of what educational programs look like and community-based providers. I know one question that Pamela and the team here have been confronted with multiple times is, how do we make a program like this work in New Mexico? You know, how do we look at costs? How do we look at faculty staffing? How do we make this real? And I think those are things that obviously need to be considered up front and at least start the discussion and sort of look at some of the resources that we can help provide. And we wanted to try to spend the next hour or so sort of learning about some models, learning about resources, and then also hearing from you. So Dr. Terry Batliner works closely with us. He is at the Center for Native Oral Health Research at the University of Colorado and runs a private dental practice. But we work closely with him, and he's done a lot of exciting modeling around costs. So as exciting as that.
Oh, it's exciting. I'm telling you. So I'm here more to tell you about the resource I can provide than to give you answers, because David talked about, you know, what does it cost to have a dental training program? Well, the answer is it depends. You know, it depends on, is it a startup? Is it a conversion? Is there existing equipment? Is there a dental hygiene program? And, you know, all kinds of things that have to be put into a model that I have that can help you get to kind of a bottom line once you develop some assumptions. So that's the idea. But first you have to endure some of my thoughts on everything. Okay, so the problem, as you all know, the problem is workforce distribution. Many locations have too few providers, and Pew just came out with a report that said there were two types of problems. One was there's not enough dentists in many areas of any kind. And then the other problem is that there are places where there are plenty of dentists, but there are too few that take Medicaid. So there's those two types of problems. And then a lot of times there's the haves and the have-nots, and some people can get access to more complex types of care, specialty care, and others can't. And transportation is a problem, especially in the places where I do a lot of work, in the reservations. And then there's a lot of issues. In Colorado, for example, there are a lot of dentists who don't see kids. So they not only don't take Medicaid, but they don't see any kids. So it makes it more difficult to get kids in. Okay. But the other counter to that, there are too many dentists in a lot of locations. Okay, and when there are too many dentists, things happen. There's a lot of aggressive care, and there are a number of institutes around the country, unassociated with universities, that, to be honest, develop approaches to care that aren't grounded in research that essentially justify an approach to overtreating patients. And this is an unspoken issue in dentistry. I frankly think it's a huge issue. You'll see a 25-year-old woman come in with a treatment plan where she's supposed to get 20 crowns. And what's the matter with her teeth? Well, not much, you know, but by buying into some of these philosophies that some of these institutes teach, it justifies that. So overtreatment becomes the norm. Prevention is overtaken by the need for production, and in many cases the hygienist becomes more of a salesperson than a preventive provider. And they provide an entrance into the practice, and it becomes about sales. So, so as you know, dentists to produce one takes 8 years. Average debt. What is the average? Do you know the latest?
Just came out about 3 weeks ago. Our last graduating class was $320,000 in debt.
Average?
We're a public dental school.
Yeah. And see, here's what happens. The ones that have $320,000 in debt, they only marry each other. They don't marry the rich. So then it becomes $650,000. Okay? And then, you know, the other issue that you have when you're trying to figure out better ways and new approaches are that there aren't a lot of faculty like Dr. Evans. I mean, there are a lot more that are influenced by the Dental Association and may not be willing to be different. So, and the average dentist makes quite a bit of money, So, you know, there are a whole lot of issues that go into trying to get people to serve the underserved and to work in rural areas. Now, there's some well-meaning badges, and here's one of my big issues, okay? The American Dental Association started out attacking dental therapists by talking about quality. Well, let me tell you where you can get the worst quality care anywhere in the country, and it's at these Mission of Mercy or other events that happen in a short term, where you have dentists doing things they don't usually do, with equipment they're not used to, in a location they're not used to, without a dental assistant or a dental assistant that they're used to. So all of those things feed in to making the quality of care about as difficult as it can get. So I think, you know, dental therapists are a much better approach than this type of thing, where people have to wait in lines like animals to get care. That's all. So, you've heard from Mary all the great things. I mean, I really think Mary's one of my heroes. and her dental therapists are really cool people, and they really do care about what they do. And they increase the accessible days for people living in villages, which is really what it's all about. You know, before, the dentist came for a week every 2 years or a couple weeks every 2 years. God, you know, I'd be the one guy that'd get a toothache the week after they left. Now, and then your choice is to wait for another 2 years or a $1,000 plane ride to get treatment, right, Mary? So, okay. So, I think dental therapists can help in a variety of different ways. First, let me talk about rural areas, and let me talk about rural areas in New Mexico, because I do work down here. And so I can tell you that the native communities down here, generally, the kids, 50 to 60% of the kids have untreated decay. Now that compares to 20% or less for non-native kids, or the general US population. So that's bad. Now, they have very high rates of early childhood decay, early childhood caries, we call it, as high as anywhere in the world, except perhaps for some Aboriginal people. We collaborate with some people in Australia, and we're kind of fighting over who has the highest rate. It's a terrible thing to fight over. But clearly, it's as bad as just about anywhere. Now, the other story that you don't hear is that access for adults in Native communities is really difficult. And adults have 75% to 97% on the Pine Ridge Reservation. Adults had untreated decay. So, and the majority of people over 65 have no teeth. And access to higher level services, such as dentures, partials, things that replace teeth, is really difficult. So that's part of the issue with dental therapists. They can help prevent the issues that lead to all these problems down the line. So rural areas, now inner cities, federally qualified health centers and community clinics could certainly benefit from dental therapists. Dental therapists can help low-cost providers, and in many communities, for example in Denver, there are corporate practices. Now those corporate practices get a lot of disparaging remarks made about them. But the fact of the matter is they do see a lot of Medicaid kids, and that is a help. And so dental therapists could certainly help these low-cost providers. I even think dental therapists can help high-end providers. Because look, if you go to a doctor, if you go to a fancy physician, like an orthopedic surgeon that has a nice office, they often have a PA who does a lot of things before you get to the surgeon. So I think it's, as you've heard, it's essential that we have the ability to do things under general supervision with dental therapists, because that's the way you can gain access in rural communities. Without that, I think you have a real problem. And the good thing about dental therapists in rural areas, they can provide access to a system of care to provide, services for the more complex issues that they have. You can, in Mary's situation, if something really big is going on, you guys get them into a system where they go to Bethel, they go to Anchorage, go to someplace where they can get treatment. So, and then it's proven that they can provide a lot of prevention. Okay. Now in the inner cities, you know, you can provide 80% of the care that dentists can. That's an estimate, but it's been shown in a variety of different ways that that's about what they can provide. They're lower cost. And one thing, one of the studies that I run is a motivational interviewing study, intervention, that we're doing on a reservation, where we've hired local people. We've trained them in this idea that was developed at University of New Mexico by a guy named Bill Miller, motivational interviewing. And they work with people to try and get them to change their behaviors. And in our case, they work with mothers of new kids to try and prevent this early childhood decay. Well, it's clear that local people can do this better than somebody coming in from the outside. It just doesn't work. So it needs to be more of a peer-to-peer relationship. And that's where dental therapists can do that better than, you know, if they're from the community, they can certainly do it better than dentists can. And that can free up the dentist to do more complex things and expand the reach of dentists. Mary said, you said one dentist usually supervises two or three or four. Mm-hmm. So that increases the reach. Okay, now some of these corporate practices can certainly benefit from dental therapists too. Now in Colorado, the typical way that you pay an associate dentist, for example in my office, is I pay them 30% of the money that they directly produce and collect. So I pay them 30% of the collections for the activities that they actually do. So, you know, we try to at least get $300 an hour of revenue on average. And so that's like 90 bucks an hour that the dentist would be paid. Well, clearly, I think you could hire a dental therapist for 40 to 45 bucks an hour in the Colorado environment. And that's half of what it is for a dentist. Now, this dental therapist can do most of what that dentist can do. Not all, but can do most. So it certainly can help. Okay, now how do you pay associates down here? Do they get paid a percentage of collections usually in private practice?
Well, I'm gonna say they do, probably similar formula.
Uh-huh. Yeah, good. Okay. And so I even think that dental therapists can help the high end, like we talked about, by freeing up the dentist to provide prosthetic care. Okay. So now, you know, how much does it cost to have a dental hygiene, or dental therapy training program? Well, you got to make a bunch of assumptions. Okay. Now, I'd like to hear what you guys think about this. I think there's really basically three types of training that dentists get. One is classroom training, where you have one faculty member talking to a group of people. And the group could be 20, could be 30, could be 100. And some, you know, often in my dental school class, we had 99 people in my class. There was one person talking to 99 people. So that was a lecture. Then you can figure out, you know, how much square footage do you need for each person and help that guide the size of the facility that you build. Then there's preclinical lab activities that in dental schools are often taught in a lab type environment. In Mary's program, they do most of it in the clinical setting, right, in the chairs. So, you know, you could either have lab space or not, but you have to do some preclinical lab things. So that means showing somebody how to cut a prep for a filling on plastic teeth before they do it in the mouth. And this is important stuff. You want them to at least have done it a few times on plastic before they get in there and really do it. So there's that type of training. And so you can, usually in that, you have a different faculty to student ratio. Kind of typically in the schools I've worked in, 1 dentist to 10 students or so. And it may be a dental resident that helps out the professor, but, you know, 1 person teaching to 10 students. Then you get into the clinic, where students have to learn how to actually treat patients. And usually that's 1 faculty member to 6 students. I think that's actually the ratio that's required. Do you agree?
Pretty close, out of Dakota, yeah.
Yeah, I think they have 1 to 6. This is recommended. And the question is how many, then you've got to figure out how many treatment rooms do you have. Now, I went to the University of Iowa, and I was really lucky because we had a chair. Every year I was in the clinic, I had a chair that I could use anytime. There was always a chair. Other schools have many more students than they do chairs, which makes it a lot more difficult. I mean, the ideal situation, I think, is to have, for the students that are in the clinic most often, to have them have a chair that they can have access to. How is it in Illinois?
Same as you described it, Iowa.
Is it? Yeah, that's good. Where'd you go to?
Minnesota is like the first speaker we had. She was there at the same time I was there.
Oh, really?
So that was kind of refreshing. And I don't run into very many Minnesota alumni here. But Minnesota was brand new at the time, during the mid-'70s. So it was a different system that they used. Anyway, it worked. But they also had 150 students in per class. So it was a big school, but that wasn't an issue. I think the way they would schedule the patients and the students, it worked.
Yeah. Some schools it's a really big deal that have too many students and not enough chairs. It's kind of sometimes it's on like a first come first serve. You got to fight to get a chair first. What, Mary? Where you went?
I went to Ohio State. We had
Plenty of chairs.
plenty of chairs.
Yeah. Okay. So ideally, I think if you're going to have a 2-year program, and most of the dental therapists spend almost all their time in that second year in a clinical setting, then I think I would personally try to have the same number of chairs as I do second year dental therapy students. So, okay. So here's the way the financial modeling works: is you just got to develop some assumptions based on the plan that you've developed. Then you're going to assign costs to those assumptions, and then you're going to work to refine those costs by figuring it out. So you also have to figure out your startup costs versus your operating costs. Okay, so let's pull up I think that's it for
You want the
oh no, we still
spreadsheet?
got, yeah, just a second, let's go back. There's one more. Go forward. Yeah. Okay, and then when so startup versus conversion, are you going to purchase all items or just some? You do have to teach students a variety of different things, kind of based on where the technology is. So for example, I asked Mary this morning, do they have digital x-rays? Yeah, they have digital x-rays, but they also do the, what would you call it? Chemical.
Wet film?
Wet film, yeah. The other approach, developed x-rays. And it's important. I just hired a new hygienist, and I said, have you ever used digital x-rays? Because that's what it has. She goes, yeah, I learned both in school, which I think is great. That's what you need to do. And it's also the same for other things, like, there's air-driven handpieces now, and there's electric handpieces. And they are a little bit different to use. And all the different types of materials that we use. People who are being trained need to get exposure to a variety of different things. So you can't have everything completely standardized. There has to be some variation in what you provide. So, yeah.
Spreadsheet?
Yeah, please. Now you won't be able to see this, but I just want to show you what we can develop. Way up to the top. Go to the top. Just way to the top. Okay. So I'll just focus on the left-hand side, and we'll just talk about the kind of things that if you want me to help you, we would spend a day or two working through, okay? For example, assumptions. What's the length of your program going to be? How many weeks per year is the program going to be open? And I kind of divide that up into, how many administrative hours is it open and how many clinical hours is it open? How many students in the program? Is there going to be tuition? So some programs, such as some American Indian programs, have very low tuitions, and that's what this one is actually developed for. And then are there additional fees, and then how often are those fees going to be paid? So just a whole bunch of assumptions, and that's really what this is. And it can only get to a bottom line if you go through all these issues and discuss them and try to make some decisions. And then as you're working towards the ultimate goal of having your program run, these things change, you know, as you refine them better. So the question is it startup funds? Is it a startup? If it is a startup, where are you getting the money? Are you going to have to borrow money in some way, shape, or form? Is there some group that you're going to have to pay money back to? And is there any interest associated with that? I just tried to make it as, you know, potentially useful for every situation as possible. So it does allow you to borrow money. And then you get into the size of the facility, the number of dental treatment rooms, the size of the treatment rooms, the extra space that you have to have. You know, you have actual treatment rooms, but then you got to have hallways. You got to have, you know, the thickness of the wall. You got to have all these kind of other things that are associated with the space to actually build a facility. So you have to put some additional square footage in there. And then preclinical labs, if you're going to have actual lab space, you have to arrange for that, and then also classrooms. So that, and then you got to have some administrative space that goes along with all that. So that gets you to some, you know, kind of assumptions about how big a facility you need based on how many students you have and how much they're going to be there and how long the program is. Can you go down a little bit? Okay. And then, you know, when I've developed businesses and then tried to get a loan, you know, they usually want 1 year, month by month by month, projection of what you're going to do. So I tried to do that with this, to develop operating costs by month. And so that requires that you think about how many days the place is going to be open every month, and it varies, you know, especially in educational programs where, you know, there's probably quite a bit of time out in November and December and other times like that. So let's see. Yeah, so I looked at the clinical operating hours per week, and the weeks per month, and revenue. Are you gonna, you know, are you actually gonna collect money from the patients who come to see you? Dental schools do. They usually do a really lousy job of it, but they do collect some money. And so there's probably going to be some revenue depending on the type of program that you have. The revenue numbers in this projection are really, really low. And then tuition, how often is tuition going to be collected? And fees, just kind of putting those things into the months of the year to get your revenues and expenses by month. Then expenses I just broke into personnel costs and non-personnel costs. So you have a program director, you have all the various faculty that you'll have, general dentists. Are you going to have any specialists as your faculty? How often are they going to be there? You know, maybe an oral surgeon, maybe a pediatric dentist. I don't know, maybe they'll be there half a day a week, maybe a day a week, maybe twice a month. I mean, those are all things you have to think through. And then a hygienist, are you going to teach dental therapists to do hygiene? Probably need some hygiene faculty. Let's keep going. And then you got to have science lectures, you got to have all these things, you know, just so these are the things that would have to be determined to figure out the cost of your program. Okay? And when you get down to the bottom, like I even have things like general support, which are guys to, you know, usually places I've been, one of the most valuable person was the guy who could fix the equipment. You know, when it broke. There's one guy that could like keep the place going. So that gives you the total personnel costs, and then non-payroll expenses, and this kind of depends on the situation you're in. First of all, do you have to pay a lease? If not, then you leave that zeroed out. You know, you have to have people to clean the place. You have to have, you know, do you have to have certain types of insurance or not? Sometimes you don't have to have that, depending on if you're a state-run institution or a tribal institution. All those things are in here to figure out your non-payroll expenses. And then you just get down to final analysis. Now don't look at these numbers and think that these are the right numbers, okay? Because this is a different situation with a different objective. The objective was to get as much money as possible from some outside donors. So we're not going to make this really cheap. We're going to say what we want to say. So, okay, but the idea is to get to final numbers about how much a program will cost. Okay? So if I can be of service to you and bring this model and sit down with you for a morning or so and customize it totally to the situation you're thinking about, or guide you in a group through a discussion about, all these various items to try and get to some cost estimates, I'd be happy to do that. Okay? So that's the kind of thing we can provide. Okay?